Hi everyone, in this video I want to address a very interesting topic. It's mechanical ventilation, and basically I want to explain why you should try to ventilate your patients, initiate ventilation and continue ventilation in pressure support, pressure assist, or pressure control ventilation, and avoid using volume control ventilation. And this is a topic that I've seen is kind of being brought up a little, here and there, but there's a huge problem associated with that. And I actually was surprised to come to United States. And in Ukraine I used to be a emergency physician. I worked on mobile ICU unit, and I'm trying to get my medical license here right now, but as I'm trying to do it, I've worked in hospitals, in ambulance, and I've seen how that works. And I was surprised by how people bluntly just put those volumes in, and they expect the ventilation to be good, and if it's not, then they don't really see the problem. They cannot understand what the problem is. So the problem is with using volume control ventilation oftentimes, and it does much more harm than we oftentimes expect it does. And especially in this time when we have a COVID issue, like many patients would be your ARDS patients, so you don't want to ventilate them with volume control. And I want to explain what is the problem with volume control and how pressure control is better. I asked people why do they do it. I didn't get any good reasonable answer, and I've seen a lot of patients come in, let's say in ER room. I work in the ER room. They come in and you can see them like awfully struggling, fighting their ventilator, and you see those volumes set up, and then patient tries to fight it every time the machine tries to push the volume in, and the pressure goes all crazy and the machine screams. And respiratory technicians, sometimes doctors, they look at it like, why is that? Like, well, maybe that's because you just bluntly set the volume expecting that that's what patient needs. And so the reason why the volume control ventilation is bad is because that's not physiological. I think I couldn't find a good reason why it's stuck so much, why everybody's using it. The good explanation I have for me is that because it has been used many years ago when the pressure sensors were pretty much complex. It was much easier to just set a mechanical, just a volume. It was much easier to calculate volume. And if you want to do the pressure control, that means that your pressure sensor also has to be a signal transducer that can control your machine to work, and you have to have, like, let's say, turbines instead of bags and this and that. So it was technically more problematic many decades ago. Now things have changed, so we don't have problem with either this and that. But the approach has pretty much stayed the same, and I think that's oftentimes just because of, well, everybody's doing that. And I've just seen one post on Facebook and people discuss and of course everybody says, well, start with volume. But why? Well, why would you want to do that? So the thing is, when we initiate a ventilation or we try to support ventilation for the patient, it is actually the pressure that is responsible for all the trauma, for all the adverse events, and everything. The volume is just a number that you set up that can trigger and offset that pressure to go very high. For example, your airways are naturally made the way that the ventilation is intermittent. So when we breathe normally, it constantly goes from negative pressure when we inhale to the positive pressure when we try to exhale. So our pressure sensors, which are much more abundant than any volumetric sensors in our body, they constantly check on that pressure if it's good enough. If there's too much pressure, oftentimes you have experienced that when you have a powerful fan blowing in your face. Naturally, you close your airways. You don't allow that to come in because there's a high pressure difference, and that's just your reflex. So patients have those reflexes, and if you try to force certain amount of volume into the patient and you're ventilating them, because all the ventilation right now is positive pressure ventilation instead of intermittent pressure, which is normal ventilation, normal respiration. So if you try to force a certain volume into the patient and you try to do it over a certain amount of time, so your flow and your pressure has to go up, oftentimes very high. And of course, natural reaction of the body would be to initiate exhalation when you try to force that in. But no, machine has a setting that it has to force in, let's say 500 ml of air, it has to push it in. So the pressures are gonna go up, the trauma is gonna occur, the your ventilation perfusion ratio is gonna go off. And so you can get patient into a shock if you ventilate them too bad. You can make pretty much an obstructive shock. So that's a very bad issue. And the easiest way to avoid this is to give them pressure ventilation so you don't exceed those pressures. And the patient is gonna allow as much air as he wants in. Rarely would you need to adjust it. In some certain cases you would, but of course you would want to go with the patient. And again, the things you want to achieve is not the volume, not even the pressure. You want to achieve three things. You want to achieve oxygenation, which means giving enough oxygen into your blood. You want to achieve ventilation, which means removing just right amount of CO2 from your blood. And you want to achieve minimally effective pressures, which you pretty much cannot target when you're using volume control ventilation. So because all of the trauma, there's a saying that there is a volumotrauma, which is actually it's not a volumotrauma. It's a pressure trauma that is called barotrauma, that is called caused by excessive volume. That's why you call it volumotrauma. The pressure is something that tears things apart, that damages, that pushes the blood out, and things like that. And you can go a lot in talking about physiology of breathing and this and that. But I just want to go straight forward and just say how to initiate and how to ventilate patients, how to achieve those three things that we talk about. So you want to have your pretty much standard settings, which you just estimate in the beginning. And then what you do, you constantly monitor all your signs and you monitor your patient, and based on that you can adjust the ventilation. So it's not like you just set certain parameter and like you're good to go and all the other parameters have to just dance around it. No, this is not how it works. You want to control as much parameters as you can. You want to monitor them. So of course, if you put in a pressure ventilation, you also want to monitor their volume, and you want to not only monitor like tidal volume, which is in fact not as appealing. You want to monitor your minute ventilation so you can see if the patient, because with the same tidal volume, let's say 500 ml, but if you have a 15 breaths per minute, that's gonna give you 7.5 liters of minute ventilation. If you giving 25, that's gonna give you 12.5. So that's a great difference in liters per minute of ventilation with that same tidal volume. So of course you wanna assess that all the things, keep the parameters going. But this is how you do it. So the estimated pressure initiated in inspiration pressure would be around 15 to 20 centimeters of water column. And of course you estimate which one you want to lean more towards. If, for example, you have a lean person that doesn't have initially any lung condition, you would try to go lower, 15, maybe sometimes lower. And if it's a obese, huge person which has a lot of fat pushing on the chest and on the diaphragm, so you want to, of course, set up pressures close to higher, but don't go too high initially. And the thing is, so that pressure setting is gonna be pretty much universal for all the patients. You don't have to do any calculations like get a chart and then look like, oh, we have a 6 to 8 mLs per kilogram. How much does he weigh? I don't know. Does anybody know? Is he actually just fat? Well, a huge fat person, and fat is maybe fairly light. Maybe he's just all muscles, and muscles are heavy. So you can have, for the same lung capacity in the same person, you can have different volumes based on their different weight, and vice versa. For the different volume, different lung capacities, you can have the same volume set up if you just set it up by weight. Because again, the somebody who is smaller but has a lot of muscle tissue, maybe has good bones, heavy, and that person would weigh pretty much the same as somebody who might be much more fatter and has a smaller, like more compressed lungs, and that person would be lighter because fat is lighter, and he might also has osteoporosis, so his bones are not as heavy. So in order to avoid all of these mistakes, you can just initiate pressure ventilation. So when you set up your pressure, again, you can then assess your volume numbers, and you just use them as kind of they're not the guide, they're just a reference. So you can see if there's a huge offset of your pressure, of your volume, sorry, then you can think of adjusting ventilation if that's needed, meaning adjusting your volume, your pressure, your inspiratory pressure. For the PEEP, which is actually the expiratory pressure, if you're talking about BiPAP, so the PEEP, usually it starts in the lower number. Rarely do patients need it to go higher. Usually it's ARDS or other patients, but this is something you might think of adjusting when you have poor oxygenation. So if your pulse ox shows that you have a low oxygen, well, oftentimes the PEEP is the way to go, because it can help you to recruit more alveoli, more lung tissue, get it to work and put that oxygen in. So of course you want to set the minimally effective pressures for both the inspiratory pressure and your expiratory pressure, or your PEEP. You want them to go as low as possible. That is because the pressure gives a damage to the lung tissue. So the way to get a minimally effective PEEP is very simple. There's many techniques described, oftentimes very crazy, with very sophisticated calculations. The thing is much more easierly. It's much more easier. So with your PEEP, you want to achieve your alveoli to stay open during the exhalation. So you don't want them to close. When alveoli close and then open with the next inhalation, then you hear the crackles. That's the alveoli opening up. So if you're hearing crackles, you might think that your PEEP has to go up, and of course, in some normal ranges. If you don't want it to go like 15 or 20, you want to avoid that. That might be very damaging. That might compromise your perfusion. So, but if you have like a pressure, you're considering a PEEP between like 5, maybe 10, and you're thinking, well, can I throw it down a little bit? Can I go down with the PEEP? Well, if you don't hear the crackles, you can try to go down. If you hear crackles, you can try to go up, see if that helps. So again, the crackles is a very simple and effective indicator of your PEEP. If PEEP is good enough, you wouldn't hear the crackles. If you hear the crackles, you need to increase the PEEP. If you don't hear the crackles, you might try to decrease the PEEP, see if that doesn't produce any crackles, and again, keep it at the lowest possible setting that you can for this patient. And of course, you put your end-tidal CO2 monitor and you check for your ventilation of the patient. So normally it should be in 35 to 40. So if your patient has a compromised respiratory drive, you of course set up the backup respiratory rate. And if the patient has his own breathing and the CO2 stays in a normal range, well, pretty much you don't have to adjust anything here. But if you see that the end-tidal CO2 stays too high or too low, well, you have to either consider changing their backup respirations, or if that's not the option, because majority of the patients would have somehow preserved breathing. Not all of them are completely paralyzed or completely breathing. So if you think that is compromised, well, then you have to consider what is keeping that parameter in the poor range. So does he have acidosis, alkalosis? Is there any insult to his breathing center? And of course, well, in some cases you want to hyperventilate per se. Like if you have a patient who is um, the patient who has got a increase intracranial pressure, you might consider trying to keep that entitled C at lower numbers, maybe around 34, 32. Sometimes you need to go lower, but it rarely happens. So usually in those cases you would have multiple people helping you out. But just with initiation, so the pressures would be you have your starting pressures, which are usually in between 15 to 20 centimeters of water column. Your inspiration pressure, expiration pressure would be usually it starts around 3 to 5. The PEEP would start in that region, and you adjust them as needed. It's not that you've set them and that's it. And of course you check your respiration rate and see if that needs to be adjusted. And of course you would have much less issues with patients trying to fight machine with the pressure support. Pretty much that's what I wanted to just emphasize in this video. I'd like to hear your comments and give it a go with the discussion. And thank you so much everybody who watched it. Have a great day.